name is John Hammond, and I'm a medical student from University of Michigan Medical School. I'm presenting as a representative of my medical student team, and under the guidance of our mentor, Dr. Jonathan Finks, we investigated correlations of marijuana use and outcomes in bariatric surgery patients. We have nothing to disclose. Marijuana use has increased nationally as more states have passed legislation to legalize medicinal and recreational use. Our state, Michigan, recently became one of 11 states to legalize recreational marijuana. The active ingredient in marijuana, THC, is known to indirectly stimulate ghrelin secretion, leading to an increased appetite. Despite this known effect on appetite, there is limited information on how marijuana affects outcomes for bariatric surgery patients. Whereas studies have found other substances to be contraindicated in bariatric surgery patients, there is limited evidence-based guidelines on marijuana use for these patients. The objective of our study was to determine if marijuana use had an impact on bariatric surgery outcomes. For our investigation, we used data from Michigan Bariatric Surgery Collaborative, which is a payer-funded consortium of bariatric surgery programs in the state of Michigan. Information on the participants of this program is included on this slide. We used results from baseline and annual postoperative surveys to collect our data. These postoperative surveys are filled out at follow-up visits for patients whose surgeons are within the collaborative. These surveys assess primary complications, reflux, depressive symptoms, alcohol use, marijuana use, and quality of life. We were able to use the responses to the marijuana use portion of the survey to assign patients to our marijuana user and non-marijuana user groups. The study included all patients who underwent bariatric surgery from 2014 to 2019, with a provider within the collaborative who filled out the survey. This included 11,592 patients that were enrolled in our study. The procedures performed on said patients include bypass, banding, sleeve, switch, and pylorus-sparing surgeries. The outcomes measured in our study included the weight loss and comorbidity remission. We determined comorbidity remission by evaluating rates of discontinuation for medications or treatment. We used a multivariable logistic regression analysis to standardize the outcomes collected. The analysis adjusted for procedure type, years from surgery, and patient characteristics. Now we can begin to look at the results from the study. First, the result from the marijuana questionnaire showed that approximately 7.5% of patients reported using marijuana. Next, we have the patients broken up by the year follow-up when they responded to the marijuana usage questionnaire. In our study, more than 50% of patients were responding within 2 years of surgery. The marijuana usage rates were fairly consistent for patients regardless of years from procedure. This table shows the distribution by the procedure. Over 99% of patients enrolled in this study had either bypass or sleeve procedures. As we mentioned earlier, the procedure type was corrected for when determining our outcomes. This table displays the baseline demographics for our study population. When comparing the two groups, the patients who used marijuana were more likely to be on Medicaid and less likely to have private insurance. Also, they had significantly higher baseline BMI. The users had significantly lower rates of preoperative opioid prescriptions, and there was not a statistically significant difference in morphine milligram equivalents prescribed postoperatively. When comparing comorbidities between the two groups, marijuana users had significantly higher rates of alcohol use disorder or other psychological disorder, higher AUDIT-C scores at baseline, and were more likely to be smokers at baseline. They also had higher rates of asthma and lower rates of hypertension and hyperlipidemia compared to non-users. 1 year weight loss was compared between the groups by analyzing the total weight loss, percent BMI loss, and percent excess body weight loss. The adjusted values for the two groups are graphed on the right, with the lighter bars representing non-users and the darker bars representing users. The results show a statistically significant difference in weight loss in all 4 outcomes measured, with the marijuana group experiencing a greater weight loss. The sizable difference in total weight loss is likely linked to the higher average baseline BMI in marijuana users, as we mentioned earlier. Clinically, the difference between the percent BMI reduction is relatively insignificant, as marijuana users are only experiencing one more point of BMI reduction compared to non-users on average. Now, we have the adjusted data for comorbidity remission between the two groups. Within this graph, the darker bars continue to represent marijuana users. As I have highlighted, marijuana users have statistically significantly higher rates of discontinuing both insulin and oral diabetes prescriptions, with marijuana users discontinuing these medications almost 10% more frequently. The higher degree of weight loss mentioned previously may account for this improvement in diabetes management for marijuana users. There was not a statistically significant difference in remission of the other comorbidities measured when comparing the two groups. Now, as we draw conclusions from the study, I believe that it is important to consider that the data is limited because it is based on one survey that only provides us a snapshot in time. We are unable to gauge from our data if these marijuana users were using marijuana more during the immediate preoperative or postoperative period, and if their marijuana usage rates changed from preoperative to postoperative. Further investigation is imperative before providing recommendations to marijuana users who are considering using marijuana during the immediate preoperative or postoperative times. In conclusion, this study shows that marijuana does not appear to negatively impact weight loss or comorbidity remission following bariatric surgery. When examining the baseline characteristics, we do see that marijuana use was associated with smoking, alcohol use disorder, and psychological conditions. Therefore, patients who use marijuana are likely to potentially benefit from psychological intervention or behavioral counseling. In the future, we hope to investigate how marijuana affects 30-day outcomes of bariatric surgery. Additionally, we hope to investigate if changes in marijuana use, both stopping and starting postoperatively, affect surgical outcomes. Lastly, we want to investigate if marijuana use affects outcomes of bariatric surgery differently with different procedure types. We would like to acknowledge once again the help from the Michigan Bariatric Surgery Collaborative and Blue Cross Blue Shield of Michigan in the making of this project. Thank you all for your time, for making this conference happen, and to all, go blue.